is the most important chapter in entire parasitology. Plasmodium. How many species are there? 4 species for a student who is writing a 10th exam, but you are writing entrance, PG entrance. So there are 5 species, and Plasmodium vivax, falciparum, malariae, oval, and the last is Plasmodium knowlesi. And all these are, of course, knowlesi is not found in India yet, but it is endemic in other places. So you have to remember something about knowlesi also. So without wasting much time, let us now directly go to the life cycle. Malaria life cycle is again very important for exam. Definitive host, intermediate host. Which is man? Intermediate host is man. Definitive host, which mosquito? Female Anopheles mosquito. And they say that if the mode of transmission is mosquito bite, then the infective form is sporozoite, but mode of transmission can also blood transfusion and vertical transmission from mother to fetus. In these 2 cases, the infective form will be merozoites. Directly merozoites can be the infective form. Okay, and in such case, if in blood transfusion, what are the differences? Merozoites, so transfusion associated malaria, how it is different than the mosquito borne malaria? If it is transfusion associated malaria, then of course, as I told you, merozoites are the infective form, and directly the merozoites will be entering to the blood. So there is no liver cycle. If there is no liver cycle, there is no hypnozoites. Hypnozoites are the dormant stage in liver. If there is no hypnozoite, then there is no relapse. If there is no relapse, there is no need to give the drug of choice of relapse, that is primaquine. All these are the differences between a transfusion associated malaria and a mosquito borne malaria. Okay. So with this, now let us start. What happens in a normal case when the female Anopheles mosquito bites? What happens when the female Anopheles mosquito bites? They say that the sporozoites are the infective form. They are released to the skin. From the skin, they will enter to the blood, and in 30 minutes from blood they enter into the liver. In liver, 90% of the sporozoites, they transform into trophozoite. The liver cycle is called as hepatic cycle or pre-erythrocytic or exoerythrocytic cycle. Both all are same, pre-erythrocytic, exoerythrocytic, hepatic cycle. And in liver, the 90% of the sporozoites, they form trophozoites. Trophozoites are the feeding stage of the parasite. They will multiply. They multiply and they will grow in number. After some time they divide, and they divide by pre-erythrocytic zygogony. They undergo pre-erythrocytic zygogony to produce a pre-erythrocytic zygote. Pre-erythrocytic zygote. Pre-erythrocytic zygote undergo zygogony to release the pre-erythrocytic merozoites. To release the pre-erythrocytic merozoites. Pre-erythrocytic merozoites are the infective form to RBC. They infect RBC. So, this happens to how many cases? How much of sporozoites? 90%. The remaining 10% of sporozoites, they are as lazy as you, they will become hypnozoid inside the liver. Hypnozoids are the dormant stage of the parasite, which do not cause any infection, but 2 to 3 years later they will produce relapse of malaria. And can you tell me how relapse is different than recrudescence? Please remember, this hypnozoid is a stage is seen only in V for vivax and oval. Only vivax and oval 10% will become hypnozoid. Falciparum all will become trophozoid. There is no hypnozoid in falciparum. In contrast, recrudescence is a phenomenon which is seen in falciparum and malariae. Falciparum and malariae, these two you can get recrudescence, and recrudescence is due to drug resistance. Relapse is due to hypnozoids. Recrudescence is due to drug resistance. They say that recrudescence occurs 2 to 3 weeks of treatment. Relapse occurs 2 to 3 years of primary attack, and 2 to 3 weeks after treatment, the drug resistance Plasmodium falciparum, if they are resistant Plasmodium falciparum, 2 to 3 weeks of treatment later, they can cause a second episode of malaria, and this is called as recrudescence of malaria. This is seen in which species? Falciparum and malariae, whereas relapse is seen in V for vivax and oval. So now come back to the life cycle, because we have discussed only half. Let us discuss the other part of the life cycle, RBC cycle. So which is the infective form to RBC? Pre-erythrocytic merozoites. So inside RBC, they say that the pre-erythrocytic merozoites inside RBC, they will grow to form trophozoites. Trophozoites, first they will form early trophozoites, that is ring form. Early trophozoites are nothing but they are the ring form. Early trophozoid later on will become late trophozoid. Late trophozoid will multiply to form zygont. Zygont undergoes zygogony. Zygogony releases the erythrocytic merozoites. Erythrocytic merozoites, once they are released, how they are released? By the bursting of the RBC. They say that RBC, the zygont, when they are released, they will burst the RBC. RBC will be lysed, so that erythrocytic merozoites will be released out. So when they are released out, along with that, the hemoglobin digested byproducts also will be released, which are called as hemojoin. You know that inside RBC hemoglobin will be there, and hemoglobin is the nutrition for the parasite. Malaria parasite feed on hemoglobin and degrade hemoglobin to produce certain byproducts called as hemojoin pigment. And along with the merozoites, the hemojoin byproducts are released, and they are the lethal byproduct which is responsible for various clinical manifestations like fever, chill, rigor. All these clinical manifestations are due to the release of hemojoin pigments. And please remember, after the merozoites are released, these merozoites will again attack the RBC to repeat the cycle. Once the merozoites is released out, RBC cycle is over. So they will again attack fresh RBC. They will again attack fresh RBC to repeat the cycle. Or if they are, or they will become bored of the person, they will transform into gametocyte. Gametocyte is the infective form to mosquito. Gametocyte is the infective form to female Anopheles mosquito. So please remember, in this context, the RBC cycle duration is very important for the manifestation to take place. Yes or no? At the end of the RBC cycle, the hemojoin pigments are released, hence the manifestations they appear. So the duration of RBC cycle is important for the periodicity of the manifestation. For example, Plasmodium vivax, and Plasmodium falciparum and Plasmodium ovale, all these three, the periodicity is 24 hours, I am sorry 48 hours. The RBC cycle lasts for 48 hours. That is why they produce tertian malaria, that is fever occur every third day. Every third day the fever appears. For Plasmodium malariae, the fever occurs every 72 hours, that is every fourth day, which is called as quartan malaria. Plasmodium knowlesi, the periodicity is 24 hours, hence fever occurs every day, every alternate day, which is called as quotidian malaria. Quotidian malaria. Okay, so this is how the manifestations occur. So whatever I have discussed, this is about the life cycle of malaria parasite, and they say that the clinical manifestation, the benign manifestation, which is common to all species, that will be fever with chill and rigor, anemia due to burst of RBC, and splenomegaly, because spleen is the site where they will try to engulf the parasitized RBCs and they will try to destroy them. As a result, the spleen will enlarge in size. So this is seen in all species, because these are the features of benign malaria. There is another form of malaria called as malignant malaria, which is seen only in falciparum, and this malignant malaria, of course, the pathogenesis I will tell you first. Why malignant malaria is seen only in falciparum species, not in other species? The reason is falciparum undergoes, in falciparum various specific pathogenesis events take place which are not there in other species. One of the important event is sequestration of the parasite. Sequestration of Plasmodium falciparum by cytoadherence and rosetting. Cytoadherence and rosetting. That this means what? They say, see, this is a RBC and this is the malaria parasite inside, Plasmodium falciparum inside. They say that Plasmodium falciparum releases a protein, expresses out a protein, secretes a protein which is called as PF-EMP protein. EMP is erythrocyte membrane protein. So these proteins it will release out. So these proteins they will come out and they will be coated on the surface of RBC. They will be coated on the surface of RBC, and these erythrocyte membrane proteins are sticky in nature. Because they are sticky in nature, this results in adhesion. Adhesion to what? One side they will be adherent to vascular endothelium. Other side they may be adherent to normal RBCs also. So that leads to rosetting. Cytoadherence means adjacent to the vascular endothelium. Rosetting is the clumping of normal RBCs to parasitized RBC. This leads to sequestration of the parasite to the vascular endothelium. So what you can see here, this property lead to what? See, this is the blood vessels, this is the total blood vessel, in that a part of the blood vessel is occluded. So sequestration of Plasmodium falciparum, especially in small capillaries of deep vessels, this leads to vascular occlusion, and this is the main mechanism why all these malignant manifestations they take place. Malignant manifestations, the various complications seen under malignant tertian malaria are cerebral malaria. Why cerebral malaria takes place? Because of the brain capillaries will be occluded, leads to cerebral anoxia. Okay. Other than that, black water fever, okay, algid malaria. Algid malaria is a shock like stage. Okay, so all these are the various complications seen in malignant malaria. Then complications seen in other species. Other species complications like nephrotic syndrome. Nephrotic syndrome is a complication specifically seen in Plasmodium malariae. Nephrotic syndrome. Tropical splenomegaly syndrome. Tropical splenomegaly syndrome, it is seen in mainly vivax or maybe in other species also. Tropical splenomegaly syndrome is characterized by splenomegaly and pancytopenia and hyper IgM. Three components will be there: splenomegaly, pancytopenia and hyper IgM. Okay, so all these are various manifestations. Fine. So now let us discuss about a bit of epidemiological features. Where malaria is endemic, which is the place where maximum number of malaria cases are found? Is it India or it is outside? India accounts for only 10% of total malaria burden. The main malaria burden reside in sub-Saharan Africa, which accounts for 85% of total malaria cases. India and other SEER countries, Southeast Asian region countries, both together they account only for 10% of total cases. And of course, in the world, Plasmodium vivax is the most common species. Whereas especially India is concerned, they say that the most common species Plasmodium falciparum and vivax is almost same. Almost same. You can say that 50% and 49%. Almost same. Followed by Plasmodium malariae. Malaria is mainly in the Tumkur and Hassan district of Karnataka. And the rarest is Plasmodium ovale. And Plasmodium ovale, they say that it is very few reports are there in India. Those places are Gujarat, Odisha, Delhi, Assam. Okay, so these are the few places where Plasmodium ovale have been reported. Okay, so Gujarat and also Kolkata you can write. Gujarat, Odisha, Delhi, Assam and Kolkata, these are the few places where Plasmodium oval have been reported. Very rare, but there are some cases. You can't say that it is not there. Can you tell me which is the most endemic state in India? They say that Odisha accounts for the most endemic, I mean the overall the endemic zone is Eastern India. Eastern India is the most endemic zone. Among that, Odisha accounts for 24% of total malaria burden of India. And in Odisha, 92% of cases are due to Plasmodium falciparum. That is where it is more dangerous. Maximum cases are Plasmodium falciparum. Okay. Then there are certain immunological phenomena. Immunological risk factor. As I told you that Plasmodium falciparum feeds on hemoglobin to produce digested byproduct. So hemoglobin is the nutrition for malaria parasite, and adult hemoglobin is the most susceptible hemoglobin to Plasmodium. Plasmodium usually feed on adult hemoglobin. However, there are certain conditions, like if you have a defective hemoglobin like thalassemia, sickle cell disease, fetal hemoglobin, all these cases they are resistant to Plasmodium falciparum, and even spherocytosis. Spherocytosis, the RBC will be fixed, it is not flexible. So this is a condition where also it will be resistant to malaria parasite. The infection cannot set in, the malaria parasite cannot infect inside. Similarly, G6PD enzyme. G6PD enzymes are essential for Plasmodium to survive. So if you are G6PD deficient, again those patients will be resistant to falciparum. Similarly, for Vivax, the Duffy blood group antigens are important. The Duffy blood group antigens present on RBC membrane, over the RBC membrane, Duffy blood group antigens are there. Those antigens are receptor for Vivax. Receptor for Vivax. So if an individual is Duffy negative, if this Duffy blood group antigens are absent, then those individuals will be resistant to Plasmodium vivax infection. So these are the various associated conditions where the risk of Plasmodium is enhanced. So with this, let us now start the most important part that of Plasmodium, that is laboratory diagnosis. After so many years of diagnosis also, after so many years of discovery also, still then they say that smear microscopy is the gold standard method. Peripheral smear microscopy. Peripheral smear microscopy is still the gold standard method. There are two smears are available, thick smear and thin smear. Which is better? Which is more sensitive? Where amount of blood is more? Thick smear, the amount of blood is more, hence it is more sensitive. It is also used for quantification. For quantification, thick smear is the best method. It is also used to demonstrate malaria pigment. It is also used to demonstrate malaria pigments. Whereas the only advantage of thin smear is it is used for speciation. For speciation, intact RBCs are required, and thick smear, the RBCs are lysed. When you make the thick smear examination, while you prepare the thick smear examination, the RBCs will be destroyed. hence the intact RBCs will not be there. For speciation you need intact RBC so that you can know which species is there inside. So now I will tell you how the speciation is done, how the thin smear is used for speciation. See, speciation is done based on 5 important properties: the type of ring form, the type of gametocyte, the type of sygont, the malaria pigment, and the RBC structure. Depending upon all these 5 properties, the speciation is done. Okay, so let us discuss one by one. Let us discuss in a reverse order. First, I will tell you about RBC. RBC, they say that for Plasmodium vivax, RBC is enlarged. For oval, RBC is enlarged, oval and irregular margin. Enlarged, oval in shape and having a irregular margin. Whereas the remaining 2, that is what? Plasmodium falciparum and malaria, RBC is normal. Coming to malaria pigment. Malaria pigment, they say that for all species the malaria pigment is dark brown in color, whereas except Plasmodium vivax where it is yellowish brown in color. By detecting which color of malaria pigment you can speciate. Sygont. Sygont means what? Sygont is a big sac-like structure having merozoites inside. How many merozoites they have? This is a property by which you can speciate how many merozoites are there inside. For vivax and falciparum, 12 to 24 merozoites per sygont, whereas malariae and oval there are 8 merozoites per sygont. 8 merozoites per sygont. And one more thing I want to emphasize here, falciparum in the peripheral blood smear examination only ring form and gametocytes are seen. Okay, the other forms are seen only in the deep vessels, not in the peripheral blood vessel. So this is again a point to be noted, because falciparum usually multiply the RBC cycle, the most of the part of the RBC cycle occurs in the deep organ vessels, brain vessels, liver vessels and all that. Peripheral blood vessel only the first form and the last form will be seen. First is ring form and the last form is a gametocyte. The remaining stage occurs in the deep vessels. That means if I ask you if you have 12 sygont in a peripheral blood smear examination, it could be what? Which species it is? Falciparum or vivax? 12 to 24 is either falciparum or vivax, but in peripheral blood smear only vivax is seen, falciparum is not seen. Next is gametocyte. Gametocyte, they say that falciparum, the gametocyte is banana shaped. Banana shaped gametocyte, banana shaped or crescentic gametocyte, whereas other non-PF it is round gametocyte. Gametocyte is round. Then the most important part, that is ring form, very frequently asked MCQ. Ring form, based on which how can you differentiate? Ring form of vivax. Vivax, what is the shape of RBC? RBC in vivax is enlarged RBC. having a enlarged ring form. They say that the ring form occupies 1/3 of space of RBC. This is the ring form or early trophozoite of vivax. Whereas the late trophozoite of vivax, of course RBC is enlarged and the ring form, the cytoplasm will become irregular, called as amoeboid ring. The cytoplasm becomes irregular, called as amoeboid ring form. So this is about vivax identifying feature. Falciparum, the RBC is normal shape RBC, having 3 variety of ring form. One is it has multiple ring form. Other one is ring form attached to RBC membrane, called as ecoliform. Ecoliform is ring form attached to RBC membrane. Then one more variety is sometime double dot ring form will be there. The nucleus is broken into 2 pieces, which is called as double dot or headphone shaped ring form, like this. Double dot or headphone shaped ring form will be there. Okay. Coming to Plasmodium malariae. Plasmodium malariae RBC is normal small, I mean not enlarged, normal round RBC, and the ring form is not actually ring, it is actually band shaped. Band forms, they are called as band forms or band shaped forms are seen in the, instead of ring it will become a band shaped. Oval, what is the shape of RBC? Oval, the RBC is irregular, oval and enlarged. It is oval in shape and irregular margin, fimbrinated, having a ring form inside. So based on the RBC you can tell that it is oval. The ring form does not have any specific feature, but based on RBC shape you can tell it is oval. So this is all about peripheral blood microscopy. So other than that, other diagnostic tool for malaria, you can go for a fluorescent microscopy called as Kawamoto technique. A fluorescent plus centrifuge, which is called as QBC. QBC is quantitative Buffy coat examination. Quantitative Buffy coat examination. Here they say that the blood is collected in a capillary tube. Blood is collected in a capillary tube, and this tube is coated internally with acridine orange. Coated internally with acridine orange. This is a stain which is used here. So once the blood is collected inside, the blood is subjected to centrifuge. So when you centrifuge the blood in the capillary tube, the blood cells will be separated depending upon their molecular weight, depending upon the density the blood cells will be separated. First the bottom zone will be the heaviest cell, that is RBC. Then you will have the lighter cells, that is WBC zone. Later on the platelet zone will be there. So like that the blood cells will be separated. Then you have to examine the Buffy coat area. Buffy coat area is examined. Buffy coat area means what? Buffy coat area is the junction of WBC and RBC. Is the WBC junction with the junction of WBC and RBC. This is the Buffy coat area. This is the area where the parasitized RBCs will be there. and this is the area which is examined under fluorescent microscope. So, this is also fluorescent stain, but along with that centrifugation is done in a capillary tube, that is called as QBC, quantitative Buffy coat examination, and they say that it is almost equal sensitivity like thick smear examination. Of course, thick smear is best, followed by QBC, quantitative Buffy coat examination. Then antigen detection, third is antigen detection by doing immunochromatographic test. Here they say that you can detect various antigens like parasitic LDH, histidine rich protein 2 and aldolase. Among the three antigen, the LDH and aldolase antigens are pan-malarial antigen. They are present in all the species, whereas histidine rich protein 2 is PF specific. It is PF specific antigen. It is present only in Plasmodium falciparum. So, if histidine rich protein 2 will be positive, that means it can confirm that it is Plasmodium falciparum. Okay. Then culture, it is not done routinely, it is done only in the research center. RPMI 1640 medium is used, and by following a method called as Trager and Jensen method. Trager and Jensen method is used using RPMI 1640 medium. It is not routinely done, it is done only in reference centers. Fine. So, this is all about the, and of course PCR, the last diagnostic tool is PCR using the various primers, and PCR is most sensitive. It can speciate all the 4 species, as well as it can detect the drug resistance gene. It can detect the drug resistant gene. Hence PCR is quite, but the thing is because it is sophisticated, it is very difficult to perform. So, it is again limited only to the higher centers. Okay, then a bit about Plasmodium knowlesi. Plasmodium knowlesi is the latest species discovered. It is a parasite of monkey. It usually infects monkeys. Not reported in India yet. Over the world, they say that around 2010 onwards, cases have been reported mainly from Thailand, also from other countries like Singapore and all, mainly from Thailand, and also from other Asian countries like Singapore, etc. Here the vector is, they say that here how it is different than diagnostic feature. They say that Plasmodium knowlesi, the early trophozoites, resembles that of Plasmodium falciparum, whereas the late trophozoites resembles to that of Plasmodium malariae, band form like it will be there, which will resemble to Plasmodium malariae, whereas early trophozoites, they resemble to Plasmodium falciparum. Multiple ring form, other forms will be seen. Okay, and as I told you, here the vector is a particular species of Anopheles called as Anopheles leucospirus. and they say that though Plasmodium knowlesi is not found in India, but Anopheles leucospirus is found in the western coastal region belt of India. So, there is a high probability that we may get Plasmodium knowlesi in near future. Okay, and of course, fever I have told you, fever pattern is quotidian pattern every 24 hours. Okay. So, this is all about. Then a bit about Babesia. Babesia is also a parasite that infect RBC. Babesia is also a parasite that infect erythrocytic parasite, but how it differs from malaria is, first of all, it is zoonotic. Various animals will be affected like cattle, etc. Here the vector is tick. Here ticks are the vector, and they say that regarding the diagnosis, ring forms are arranged in tetrad. Inside the RBC, tetrad of ring form will be present. This is called as Maltese cross form. Maltese cross form. And of course, the drug of choice here is tetracycline. In contrast to Plasmodium, it is resistant to chloroquine. Plasmodium chloroquine is the drug of choice. Here it is resistant to chloroquine, and it is tetracycline is usually given for treatment. Clindamycin also. Clindamycin also is given for treatment. Okay, and the other difference is, they say that it is more important in splenectomized and immunocompromised individual. This is the risk factor. Splenectomized and immunocompromised individual, especially Babesia bovis, is a species which is usually it affects the splenectomized and immunocompromised individuals. Okay, and another point to be remembered, there is no cerebral malaria feature. There is no cerebral malaria manifestation. In contrast to malaria, here there is no cerebral manifestations are there. Okay, so these are the differences between Babesia and malaria. This finishes this chapter. Sites.